Kia ora and welcome to this session, which is a short overview of the expectations for the 10-step analysis method that we use throughout the cardiology course. First and foremost, the 10-step method provides a structured way to collect and then process information from an ECG. And as this course has a strong focus on recognising risk and supporting diagnosis outside of the STEMI paradigm, there's going to be a deeper dive into the intervals, the duration, the morphology of waves and the like. And the data acquisition phase of the 10-step is the foundation for this analysis. Secondly, is how you're expected to process and display knowledge in the majority of the formative and summative assessment work for this paper. For the block course exercises, this is the way in which we're going to process the practice ECGs. So, let's explore the expectations of this model. The first element that is explored is regularity. This is essential in helping understand the nature of the cardiac rhythm. And in the broader sense, rhythms might be regular or irregular. And at this level of study, it's the predictability of where the next waveform will fall that has been examined. For the most part, it's the R to R interval that's going to be examined. But where irregularities occur, we also need to look at the P to P interval and the regularity of the PR interval. So there's three definitions that can be used to complete this section on the template. The first is you might describe a rhythm as being regularly regular. For this definition to be true of any cardiac rhythm, the R to R intervals are essentially equal in length. In general, if the difference between the R to R intervals is less than 0.08 of a second, that is two small squares, and there's a predictable sequence to what's happening, then the rhythm is considered to be regularly regular. The next determination you might make is that the rhythm is regularly irregular. So in this case, if the difference between the R to R intervals is greater than 0.08, that is more than two small squares, and this change is happening in a predictable and repeating sequence, is described as regularly irregular. The classic examples of this would be a ventricular bigeminy, maybe a second degree AV Mobitz 1, the Winkie-Barker type block, or something like a sinus arrhythmia. The last determination that you might make is a rhythm that would be irregularly irregular. So in this case, if the difference between the R to R intervals is greater than 0.08 of a second, and there is no predictability as to where the next R wave will fall, is described as being irregularly irregular. And the archetypical example of an irregularly irregular rhythm is atrial fibrillation. The next thing to determine is the electrical rate. This is also an essential element to determining the cardiac rhythm. You're likely to be familiar with three methods to determine this, and the gold standard that we're recommending is extrapolating from a 10-second strip. That is to say, you count all the R waves over a 10-second rhythm strip and multiply this number by 6 to estimate the minute rate. You're probably familiar with the 300 and the 1500 methods as described in Hussars. Now these are useful when the rhythm is regular, but notoriously unreliable when this isn't the case, and hence the gold standard to determine the minute rate from a 10-second strip. Next on the list is to determine the cardiac axis. For this paper, the requirement is to determine which quadrant the QRS axis falls in. It suffices to note this as being either normal, right, left, or indeterminate, and this is based on the polarity of the QRS deflections in leads 1, 2, and AVF. This information will help determine the nature of non-acute cardiac syndrome related changes, such as hypertrophy, for instance. The fourth element in the template is a description of the P wave. The morphology of the P wave gives clues to two aspects. The first is the genesis of whatever atrial activity is being shown on the ECG. and for the most part, an upright and rounded P wave in lead 2 signifies atrial activity that's been triggered by the SA node. In other words, an upright and rounded P wave in lead 2 is associated with a sinus rhythm. So, alterations in P wave polarity are associated with other atrial pacemaker sites, while alterations in the morphology of a positive P wave may be clues to things such as atrial enlargement or overload. The fifth element that we are examining with this template is the PR interval. The PR interval indicates the association of the atrial and ventricular polarization. It's useful in determining the cardiac rhythm, and for the purpose of this template, it needs to be measured in milliseconds or parts of a second. And this part of the template also requires you to note and comment on whether the P wave and the QRS complexes are actually associated or not. And typically, if there was a third degree heart block, you might sort of say that there was no association between the P waves and the QRS. The sixth area on the template relates to the QRS complex. There's a major amount of work occurs in this part. So it requires significant attention to the duration of the QRS, because this will determine which process is used to isolate the pertinent data that you need and what can be analysed from this. Crucially, the duration also determines whether the analysis of the ST segment can be achieved using the normal ST segment criteria. So let's have a closer look at this. The QRS complex is always measured and recorded in milliseconds or parts of a second. Should the QRS be narrow, this implies normal ventricular conduction. If so, further analysis is based on the presence of pathological Q waves, precordial R wave progression, and abnormalities in the height of the QRS components. This might include tall R waves in V1 or large amplitude waves that meet the voltage criteria for ventricular hypertrophy. It's important that you note which leads or lead groups show Q waves or other changes, particularly if this is related to an ischemic presentation. On the other hand, should the QRS complex be wide, that is, it's greater than 0.12 seconds, it implies a conduction block in the ventricles, and that the subsequent repolarization sequence makes examination of aspects such as Q waves, QRS amplitude, R wave progression, and even ST segment elevation or depression relatively ineffective. Instead, identification of the nature of the conduction defect, such as a left bundle branch block, right bundle branch block, or an IVCD, is more relevant. And in the setting of ischemic presentations, rather than using ST segment elevation, we're going to have to use something such as the modified Scar-Boser criteria to indicate whether there's an AMI occurring. The seventh element on the template is the ST segment. So paramedics appreciate the role of the ST segment in determining the presence of ischemia. This portion of the template requires you to note the presence or the absence of congruent ST segment elevation or ST segment depression, and which leads or lead groups are involved. When aligned with clinical or the historical features that are given for a case, it can also help identify other pertinent features such as ventricular hypertrophy, STEMI mimics such as pericarditis, or other ion imbalances. And just remember, in the case where there was a wide QRS, these usual ST segment criteria are ineffective, and we have to think about things such as the modified Scar-Boser criteria. This brings us to the eighth part of the template, which examines the T-wave. T-wave alterations can also indicate ischemic changes, and the main points to cover in this section of the template is whether or not T-wave inversion has occurred where it is not expected. Now, we'll go into greater depth of this during the course, but some T-waves will be normally inverted and some normally won't be, so it's important to make that distinction. You'll also need to cover whether there are hyperacute T waves and note which leads or lead groups are involved in this. And lastly, you may consider whether there's some sort of clinical correlation to other factors of the case that might increase the amplitude of the T waves. And maybe the archetype for this would be a clinical history that suggests hyperkalemia. This brings us to the 9th section on the template, which is interpretation. In the clinical and academic settings, this is clearly a very essential part of the process. And from an academic perspective, 50% of the marks for the ECGs, for instance, are allocated to the interpretation section. So ensure you consider all of the following points when you are describing the rhythm. So you need to name the cardiac rhythm, and this includes whether it's a sinus rhythm. Don't assume that because you haven't noted that it's an abnormal rhythm, that it implies it is sinus. You do have to be very clear about this. You need to record any other alterations or punctuations of the underlying rhythm, such as, say, premature atrial contractions, a nodal block, or maybe there's bursts of a non-sustained tachycardia that are going to require commentary in this section. And note any alterations to conduction in this section. So when you went through the QRS part and found there was a wide duration and it was a bundle branch block, very good to note what the final determination was in this section of the template. You need to provide an interpretation regarding the presence of an infarction or ischemia. And the last thing you may need to consider is interpretation of any other changes. So, for instance, if there was voltage criteria met for ventricular hypertrophy, if the case in the ST segment, case details, and the ST segment elevation on an ECG indicated pericarditis or whatever. This is where you would make a very clear indication of what your interpretation of all this is. And the final section of the template requires a brief indication of the underlying pathology that's been exposed by the ECG. So in the case of ischemic changes, such as simple as, say, a STEMI, your job is to identify the most likely culprit artery. For other ECG abnormalities, just a very brief statement that indicates what the ECG change relates to. So if you were dealing with a pericarditis case, for instance, you might indicate that there's an inflammatory process involving the pericardium, or if it was hypertrophy, for instance, and the patient had a history of hypertension or something like that, you'd probably, say that the hypertrophy was secondary to essential hypertension. But it needs to be a very brief identification as opposed to any in-depth explanation of why the ECG has changed. I hope this has been helpful. The template that's an explanation that's on the Moodle page covers all these points a bit more briefly, so it might be a good way to ensure that you review the use of the template and make sure that you maximise both your ability to provide an interpretation and your marks for any of the tests. I'll leave you with that for the time being. If you've got any questions, feel free to get hold of myself or Cam. In the meantime, ka kite.